Hi. So today we'll be talking about comparative effectiveness of aspirin dosing in cardiovascular disease, or the Adaptable trial, which was published in NEJM in 2021. It was also presented at the ACC conference in 2021. So first question arises that why was this trial needed? This trial investigated if there was a meaningful difference between 81 milligrams and 325 milligrams once daily dose of aspirin when taken for prevention of atherosclerotic cardiovascular diseases. Why was this trial needed? This trial was needed because while ESC, or the European Society of Cardiology, has a definite recommendation for low dose aspirin in patients with stable CAD, ACC/AHA guidelines do not provide any definitive recommendations on aspirin dosing in patients with established atherosclerotic cardiovascular diseases. So the use of high dose aspirin or 325 milligrams of aspirin is rampant in the United States. The Adaptable trial was an open label trial, and more than 15,000 patients were randomized to either 81 milligram aspirin group or the 325 milligram aspirin group. The median follow-up period was 26.2 months. The baseline characteristics of the patients in both the groups were comparable. The mean age of the patients participating in the trial was 67 years. Female comprised approximately one-third of the patient population. Approximately 80% of the patients were whites. Around one-third of the patients had history of myocardial infarction. Half of the patients had received some form of coronary revascularization. Around 40% patients had history of previous PCI, and approximately one-fourth of the patients had history of previous CABG, or the coronary artery bypass grafting. More than 80% patients had history of hypertension. More than 80% patients had history of diabetes. Atrial fibrillation was present in around 8% patients. Approximately 6% patients had history of previous significant gastrointestinal bleeding. Around one-fourth of the patients were on a P2Y12 inhibitor. And in more than 90% of the cases, it was clopidogrel. The trialists found no significant difference in both safety and efficacy of 81 milligrams of aspirin and 325 milligrams of aspirin. That is, there was no significant difference in primary efficacy outcomes of death from any cause, hospitalization for myocardial infarction, or hospitalization for stroke. And there was no significant difference in hospitalization for major bleeding. 7% patients in 81 milligram aspirin group had discontinued aspirin, whereas the discontinuation rate in the 325 milligrams group was 11%. That is, discontinuation rate was higher with 325 milligrams of aspirin. The reasons for discontinuation were similar in both the groups, and they included patient's preference, the need for an oral anticoagulation, bleeding or bruising, and others. What do the authors, or what do we conclude after reading this study? We conclude that 325 milligrams of aspirin is not superior to 81 milligrams of aspirin. And for most patients with established atherosclerotic cardiovascular diseases, aspirin 81 milligram likely remains the preferential choice because of its enhanced adherence. Thank you. That was the presentation, guys.
We will be back with more videos on recent advances, recent guidelines, and recent articles in cardiology. Follow CardioEd for more such content. Like and share the video and subscribe to CardioEd.